In today's video, we will mainly discuss about multivitamin supplementation, which is often considered as a defensive polypharmacy. What does it mean? We will just think whenever the individual complain of vague fatigue and all, supplementing with multivitamin will be helpful. But we will be ignoring the exact requirement of that particular individual, the targeted micronutrient supplementation based on the profile of the patient, as well as what mistakes we are doing when we are prescribing multivitamins. What is the ideal way to utilize these supplements in OPD patients and admitted IP cases? What is the ideal composition of multivitamin pill in relation to Indian population? And some of the landmark clinical trials related to multivitamin supplementation will be discussed in today's video. So the first thing is, we will look at a glance which is happening in relation to prescription of multivitamins. We are not classifying the phenotype of the individual. Just for all the vague complaint of fatigue, we are prescribing multivitamins. But ideally, we have to specifically target the deficit. For example, whether the individual is geriatric or having some metabolic abnormalities or restrictive intake. So all these things should be assessed before just randomly prescribing multivitamin for fatigue. This is the first point. Then, regarding monotherapy for the disease, whenever there is deficiency of one particular micronutrient, we need not to supplement with the multivitamins. Instead, we have to target that particular micronutrient. For example, vitamin D deficiency, isolated iron deficiency. So in that case, multivitamin should not be supplemented. Instead, we have to focus upon the actual deficit. Third thing is regarding the ideal pill for Indian setups, which has to contain 100% of the recommended daily allowance, and what should be there in that pill, we will discuss about that. And one more important thing which we have to remember during prescription is the duration bound prescription should be followed. That is, when we start, there should be an end point as well. Do not advise it as indefinite refill. Mostly in some malls and all, you might be seeing when you purchase some drink and all, they will be giving the coupon using which you can refill the drink indefinitely. That should not be applied to multivitamins. There should be a time bound therapy in case of multivitamins. Where we are going wrong, ignoring such minor details will end up in toxicity sometimes. For example, many of the multivitamins will be having vitamin A, especially in the active form, that is retinyl palmitate, which if we don't focus upon can lead to hepatic overload and systemic toxicity of vitamin A. This thing, if we don't focus particularly, is a kind of misutilization of the pill. Similarly, many multivitamins will be containing vitamin E as well. So if it crosses to more than 400 international units per day, it has been noted that there will be increased risk of hemorrhagic strokes. Again, this thing, if we don't focus particularly, will be definitely ignored. Even some multiminerals will have high doses of zinc. So definitely this divalent will lead to the deficiency, relative deficiency of the other micronutrient, which is very important when it comes to bone marrow health and liver health, that is copper. So high dose of zinc supplementation will lead to copper deficiency, leading to anemia, neutropenia, and even liver damages. So what we should do ideally? We have to first fix the phenotype of individual and look for the exact deficiency of that micronutrient. For example, if the individual is geriatric, that is more than 60 years, we can lose it down when it comes to Indians. You just consider above 50 years. What happens is, because of numerous mechanisms like atrophic gastritis, there will be impaired B12 cleavage during the absorption. Also, there will be reduced vitamin D synthesis from the body. So, the primary targets in these population should be vitamin B12 and vitamin D. Similarly, in case of diabetic individuals, there might be numerous micromineral deficiency because of the renal wasting and chronic inflammatory state. Commonly, we see hypomagnesemia and zinc deficiency, and which will interplay with the worsening of disease. So in that case, we have to supplement with magnesium and zinc particularly. And in some individuals who are having restrictive eating, like strict vegans or even vegetarians, we can consider, there will be complete absence of animal derived micronutrients. And in Indians especially, we have carbohydrate heavy meals intake pattern, which will also lead to the deficiency of B12, iron, zinc, and vitamin A. So if these are the individuals, we have to target primarily upon these micronutrients. Similarly, if the individual is having some malabsorption disorder or underwent bariatric surgery or having celiac disease, Crohn's disease or chronic pancreatitis kind of illness which is leading to malabsorption of numerous micronutrients, they will be facing deficiency of fat soluble vitamins. We have to target particularly that micronutrient. Like that, we have to first decide the phenotype of patient. Now once we have decided the phenotype, how we have to manage in OPD and in admitted patients, that we will discuss now. Especially when it comes to outpatient management, as mentioned, first decide whether there is any particular micronutrient deficiency, for example vitamin D or iron deficiency. In that case, treat it as targeted monotherapy only, not with the multivitamins. But suppose you feel there is subclinical deficiency of numerous micronutrients, which is very common in Indian setups. So in that case, single maintenance pill of multivitamins and multiminerals should be advised. Remember, this is the maintenance pill because the individual is not able to take in the diet. This is not the correction of deficiency which has happened, and generally this pill should be advised for 1 to 3 months and we need to reassess it, not like refill indefinitely. So there should be a time bound therapy for all these multivitamins. Coming to IPD, here again decide the particular deficiency and do not consider the vague fatigue as the requirement of multivitamins. So what we have to do, for example, you commonly come across alcoholic malnourished individuals. In that case, we need to focus upon thiamine. Similarly, if the individual is in ICU or in severe sepsis, there will be high oxidative stress leading to depletion of multiple micro minerals like selenium, zinc and vitamin C. So these things should be supplemented in that admitted patient. And in some post-operative cases for healing, they need vitamin C for collagen synthesis and zinc for epithelialization. So these two particular micronutrients should be focused upon. So when we compare IP and OPD care, mainly in IPD setups for metabolic stabilization, as discussed, ICU cases, sepsis cases or alcoholic malnourished individuals, we will be giving the targeted therapy mainly for short term like 7 to 14 days, and it should be targeted repletion. Whereas in OPD setups, if you see subclinical deficiency, for maintenance we will be giving multivitamin pills for 1 to 3 months, which is duration bound, and we will be reassessing after 1 to 3 months. It is mainly maintenance therapy or targeted monotherapy. What are the other pharmacokinetic mechanisms which we have to remember while prescribing these multivitamins? For example, when it comes to calcium inclusion in the multivitamin, we should be knowing that stomach acid will have a greater role. For example, if it is calcium carbonate and if the individual is having achlorhydria or on anti-acid medications, this form will not help them because calcium carbonate needs stomach acid for the absorption of calcium. In that case, we have to prefer calcium citrate form. This I have discussed in detail in one of the previous videos on vitamin D and calcium supplements. Similarly, we have to focus upon the timing as well. For example, the water soluble vitamins like B complex or vitamin C should be taken in the morning on empty stomach for better absorption. Similarly, iron, the micronutrient, should be taken on empty stomach ideally, but you have to be careful regarding the gastritis symptoms. In that case, keep on trying with the various brands till your patient will get adjusted to one particular brand. For different individuals, different brands will be suitable. So you can try that. Even upon that, if you feel there is persistent gastritis, we can advise them to take it along with the food. And as B vitamins are quite stimulating, avoid them giving at the night time. And regarding iron, it must be strictly avoided with tannins and phytates. So this is the problem if they take iron along with food or if they consume tea or coffee in and around the intake of iron pill. Also, iron as well as calcium should not be given together. They will inhibit each other's absorption. So if you know all these things, you will be focusing upon the composition of multivitamin and multimineral pills so that in case of specific deficiency, you will avoid such mistakes. Similarly, for fat soluble vitamins like A, D, E, K, usually we will advise them to take it along with the heavy meal of the day. mainly lunch or dinner, because such meal will stimulate bile acid secretion, which is very helpful for the absorption of these fat soluble vitamins. Now, to say what is an ideal multivitamin pill for Indian population is, we have to see for these minimum parameters in the pill. For example, there should be minimum 2.2 to 2.4 microgram of vitamin B12, which is the daily requirement for any individual. B12 deficiency is very common. That's why minimum daily required dose should be there in the multivitamin pill. Similarly, folic acid, at least 300 microgram should be there. Vitamin D, 600 to 1000 international units. And magnesium, which is very helpful in many metabolic disorders, including diabetes. So minimum 250 to 300 milligram should be present in that pill. And when it comes to zinc, which is very good for mucosal immunity and epithelialization, minimum 15 to 17 milligram should be present. Overall, we need to target 100% of the RDA for Indian population. Finally, some of the landmark clinical trials with regards to multivitamin supplementations are Cosmos trial. Mainly it is based on the Western population, which has shown that routine supplementation will fail as primary prevention in well-nourished populations. So, for them, especially Western population, this routine supplementation even after 50 years age, especially in well-nourished population, is not beneficial. But it is not same for Indian population. According to ICMR data, 50 to 70% of the Indian population exhibit subclinical deficits. So Indians, especially after the age of 50 years, need multivitamin supplementation. But again, all these things should be followed up. Look for the specific deficiency of any micronutrient. If it is there, target that first. Otherwise, in general, above 50 years, if we are supplementing, look for the ideal pill composition, then only advise it, and that too, duration bound advice should be followed. So the overall point is, compared to Western population, the similar data will not be applicable to Indian population, where the subclinical malnutrition is very, very common. So finally, as mentioned in the first slide, from now onwards, we will be following few of the important points when we are prescribing multivitamins. That is, first we will decide the phenotype of the individual to look for specific deficiency or in general deficiency. Then if there is specific deficiency, we will be giving monotherapy for that particular disease, commonly vitamin D, B12 and iron. And we should know about the ideal Indian pill, which has to contain B12, magnesium, folate and zinc, and ensure that it is 100% of the Indian recommended daily allowance composition. Similarly, always the prescription should be duration bound. For example, 1 to 3 months, and you have to mention to come for the reassessment and look for any changes, improvement and further requirement of the continuation of the pill or not. Do not follow refill indefinitely strategy in case of multivitamins. I hope you have understood the concept regarding multivitamin, which is actually very beneficial in Indian population, but if you don't know the concept proper, it can be a misutilization. Please share it among all your batchmates, residents and the practitioners, so that we will have the basic idea about multivitamin prescription, especially to those who are very fond of these multivitamins for all the vague fatigue even in younger population. See you in another such informative, clinically useful video. Till then, take care. Do not forget to subscribe our channel. Thank you so much.